Hello and welcome to another episode of the Melbourne Athletic Development Podcast. Jack?
John.
Today we wanted to talk about a case study. And recently we spoke about what happens when things don't really work the way that you thought they might or expect. And we thought we'd use a case study in this example and this chat to explore maybe some concepts that people haven't thought about, explore some of the ideas that we've discussed in podcasts, but we wanted to put it into a really practical setting.
Yeah, and I think it's actually a really good example of a common presentation seen in athlete populations and what turned out to be following kind of very typical ways that you address this particular injury, but not actually seeing the outcome
that you thought was appropriate.
That I thought was appropriate, and actually then coming back to thinking, well, is there something that I'm missing within the puzzle here?
So do you want to, obviously this was a patient that you specifically saw.
Yeah, so just to give you some context, this guy in his late 20s, I've actually seen him previously for some other injuries. He's had some groin pain before. He plays Australian rules football. So
at the local level or?
Yes, yeah, like he plays in a country league. So like at a reasonable level, but it's not
professional.
Not an elite athlete.
And he works, obviously?
He does, yeah. So he's a teacher. So he actually presented with very classic proximal hamstring tendon pain.
Yeah, it was pinpoint to
very localized, right over the proximal hamstring conjoint tendon. Very much followed the tendinopathic type of pain, where he would be sore, it would warm up. He even had some soreness associated with compression, like things like prolonged sitting. So very much seemed very clear what was going on.
What the diagnosis was, at least.
Yeah, there was nothing
stood out, and there were no sort of strange symptoms. Things
no neural
related
symptoms,
to neurological pain.
Correct.
Anything travelling down the leg.
Exactly.
Had he had a history of hamstring strains in the past?
So he had, before he'd had a hamstring strain on the same side 3 years prior. And it had.
Do you know if it was a significant one?
Not too significant. No, I hadn't seen him for that. So I had only started seeing him maybe 6 months before he presented with this. And actually, with that in mind, he had some similar symptoms prior over the last couple of years. So potentially, well, in fact, I think very relevant, as will come on later, that some of his prior injury history may be related to some of the ongoing issues that he had with his hamstring tendon pain. And so he plays footy, but he certainly was at a pretty high functional capacity still.
And he was still playing at this point?
He was still playing. So I first started seeing him actually at the end of the footy season for this. He was really keen to get on top of this because
it was
prior to that,
modify what he was doing a little bit.
Correct. Yeah, he's actually not from Melbourne. He was also seeing another physio who I know. He'd been working with him to get management of the issue through the season. He managed to get through the season okay, but he's really keen to get on top of this. And so, not surprisingly, after we came up with understanding what the actual particular problem was, going through like the typical type of framework and assessment that I would do for a tendon type problem. So getting some indications of his tissue capacity. And interestingly, and not necessarily surprisingly, he certainly had some deficits on his hamstring strength in that side. In fact, actually quite significant. Just looking at my notes here, was 41% reduction in his peak force.
So it's not surprising that he actually developed overload to the tendon, because clearly that side was not functioning at a level that was commensurate with what he probably needed in terms of symmetry, at least.
Yes.
For playing AFL football.
Yeah, and I don't think we've actually talked much about this before, but when assessing hamstring strength, we can obviously look at basic measurements like knee flexion or hip extension. Certainly his biggest reduction was more in knee flexion. If we look at, say, more complex tasks, like, say, doing some single leg bridge type assessments, which we use for looking at hamstring function, interestingly, that wasn't as reduced as, say, just knee flexion by itself. It certainly was reduced, and there's certainly some reductions in his rate of force development, but not as significant as his actual peak force. And interestingly, I think that's relevant to it, he certainly had some reductions in some other planes in that hip. So like looking at AD adduction.
This is in movement or in strength?
In strength, that is.
So force output, yep.
Yeah. Certainly some restrictions in his rotation in the hip. So, based on just looking at this information, started trying to actually address some of those issues.
Was this his kicking side or predominant kicking side?
No, it wasn't.
This is his stance leg.
Stance leg, yeah. So, keeping that in mind, thinking about what kind of strategies we can use to potentially manage symptoms of his hamstring pain. And it's interesting, actually, he was someone who wasn't so much of a responder to doing things like isometrics. So that certainly wasn't a big part of his management acutely.
What would happen when he did that? You just didn't get a response?
He didn't get much of a response.
So it wasn't better, wasn't worse, it just didn't really change anything?
Exactly, yeah.
On that, actually, with relation to tendons, do you think that in itself is something that you... Like, how do you respond to that? If someone has minimal or no response to an intervention, what's your sort of thinking when that occurs?
Well, actually, I have thought about this, and I actually think it's relevant to this case. And I wonder, this is my assumption, very limited assumption or hypothesis of what's actually going on at a cellular level. Because when you apply any type of mechanical load, I think the good thing about an isometric load is it's very linear in the force application. You're creating a tensile force at the tendon, which is going to influence fluid dynamics. So my assumption, and I've heard some people talk about this, is it related to peripheral changes at the tissue level, or is it maybe, say, a centrally mediated change? It's probably multiple things. But whether someone who has a positive response to isometrics of, are you creating tensile load, it changes the fluid dynamics, and therefore even potentially like the mechanical pressure within the tendon, that leads to a reduction in the threshold of those receptors sending a nociceptive signal. So if someone doesn't respond to it, I wonder if there's an issue with the coordination of how the muscle is contracting and creating tension on the hamstring. And I mean, this is something that is
it's a hypothesis.
Very anecdotal, of course. I'm not sure if there's any research looking at this. There is certainly research showing that there is changes in neuromuscular patterns associated with tendon pain. But I wonder if that's often the case with regards to people who don't respond to it, is you're not necessarily addressing that neuromuscular dysfunction that creates essentially non-optimal loading through the associated tendon.
Yeah, well, that would make sense. Even as I said, at a hypothetical level, it makes sense, because if the tendon is not responding to mechanical load in a healthy manner and in a way that you would expect, it shows that the neuromuscular patterning is leading to some sort of asymmetrical or, mistimed or miscoordinated application of mechanical tension through the tendon itself.
And it makes a lot of sense too, and this is sort of going to a whole nother discussion we can have, and probably need to get someone else to talk about it, but thinking about the subtendon components and thinking about shearing that occurs, which seems to be, well, one, is certainly a very important thing for healthy tendon mechanics, but it's actually also really important for signaling in regards to those shear forces provide a strong mechanical signal that causes tendon adaptation, both within the actual interface between the subtendon, but potentially the tendon itself. But going back to this presentation, so as I described, certainly some restrictions or deficits in peak force of the hamstring, certainly some restrictions in hip range of movement in the rotational plane. Actually looking at things like passive straight leg raise were fine. If we think about it from a biomechanical standpoint, he actually had pretty good mechanics. If we think about looking more at that elastic function, it was something that wasn't fantastic, but it's actually something that we'd work on before because of his groin pain, where looking at something like his RSI, initially it was only about, say, 2.5, but he got that up to over 3.
And when you say biomechanics, are you looking? What were you looking at there? Were you looking at running, jumping, change of direction?
So this is more related to a running task. Yep. Yeah.
And was his pain, particularly from a biomechanical standpoint, related to any specific biomechanical task? Like what were the main things that were irritants?
So high velocity running was the biggest one. And this is where it started to get interesting, because certainly when we started to apply interventions to work on building up his hamstring strength, addressing some of those other deficits, we started to see some improvements in his peak force output, in his knee flexion. But it was interesting to note because as we reassessed, a lot of these other measures, hip AB adduction, adduction, his flexibility improved quite significantly.
Yeah.
Like some of these got down to basically like a 0% asymmetry.
Yeah.
That hamstring strength though that deficit was still there. And keeping in mind, initially because it was the off season, we modified his running load to really be able to focus on building up some of those strength capacity. So he wasn't necessarily doing any aggravating factors. But every time that we go back to assessing his knee flexion, it wasn't really making that jump. It wasn't really making as significant an improvement as I would expect based on the fact that we were really focusing on building up that capacity.
And how, like in terms of you saying you modified a few things to get more of that loading in, like how often was he loading? What was the kind of protocol that you were following?
Yep.
Did you sort of use some sort of framework? What, because people will ask, okay, well, because I'm sure they can tell from what we said, like he's not going to reach the outcome that we wanted from the things that you were doing. What were the things that you were doing so that people, might have an idea of like, okay, well, that's similar to what I would do.
Yeah, and actually just even to speak more broadly, like we've talked about some of the tissue capacity factors, there wasn't really any large biomechanical factors that we need to assess. And actually even from a hormetic profile, he was someone who was young and healthy. One of the great things about him, very compliant. He's the kind of guy who, you make recommendations, he'll do it. You prescribe certain loading interventions, he'll do it. And so like he was very regular with going to the gym on a regular basis to do a lot of hamstring specific loading. And that was like in the form of, again, nothing too special, doing some hamstring curls, doing things like some more advanced things like Nordics or even like single leg bridges, doing some hip thrust variations. And even over time actually building up, doing some more hip specific hamstring loading too, when we think about like say back extension, good morning variations. And, he actually seemed to respond fine to that in terms of not having a negative effect from, like, say, compressive loading from going into too much hip flexion.
Yeah, so you were able, basically, you followed a general progression of starting with, more basic and lower magnitude intensity tasks and building that up, increasing the range of motion, increasing the amount of, as I said, compressive position, different biomechanical tasks, and higher magnitude. And I'm sure you're probably about to say, but like, did you then start progressing towards higher velocity inputs as well?
Yeah, exactly. So, over the first few months within, I can't remember the top of my head, but let's say at around that 4 to 6 week mark, he was starting to do already some slow velocity work just to actually do some metabolic conditioning, but started to build up doing some more high velocity work in the form of some interval training, in the form of acceleration work, in the form of max velocity work, and building up the intensity over time. And interestingly, he was responding. He was able to tolerate most of those loads until he started getting to the really high velocity work.
So it was very specific to that velocity.
Very specific, yeah. And so, initially I was thinking perhaps what we need to really do is actually work on building up the elastic capacity of his tendon. Perhaps what we need to really do is focus on building up stretch shortening cycle movements so he actually builds up those properties that he needs. And again, we actually started to see improvements in his ability to do those particular tasks and build up the overall volume and intensity. So again, in many ways, he's really heading in the right direction. It's not so much that there wasn't stagnancy or he's heading in the wrong direction.
Yeah, but you just thought the rate of improvement wasn't what you were hoping to achieve.
Well, and the other thing that kept standing out is that knee flexion peak force wasn't going up.
Yeah.
So he was clearly developing strategies to overcome that deficit. But obviously that raises alarm bells to me too, because you can easily say, oh, look, you're meeting all the KPIs we want, you're building up your high intensity running, you're really ticking all the boxes. Maybe you just this is going to be something that you just have to manage long term. And actually at this point, and again, he was really open to this, we implemented other strategies, whether that's things like collagen supplementation. We even played around with doing things like blood flow restriction training, which I think we've talked about before, thinking about creating metabolic stress as a really valuable signal for maximizing tendon adaptation. So we had really exhausted, I think, what you would consider sort of the main
mechanical loading features.
Correct.
And the things that are associated with that. Or you probably hadn't completely exhausted them, but you were using many of the features that you would typically use and hoping to get a response that's more akin to, as I said, progression in those key measured areas.
Yeah, and I think particularly too when going into a few months into it of thinking, well, he's making these progressions, he's pretty happy with his actual the direction he's heading in, but I guess there's always a part of me of like, is there something I'm missing? So again, thinking about that framework we use, nothing really had changed in his hormetic profile. I mean, particularly at this point, it was in January, so he was on school holidays. So
he's not working.
Doesn't actually have a lot of work-related stresses in his life at that point.
Had he started pre-season already again?
He was doing only the stuff that we'd been working on with regards to stuff in the gym and some running tasks. Biomechanics I was never too concerned with. Tissue capacity, he's still working on all those things that we mentioned. But I was thinking, well, is there something that I'm missing? And something that we've talked about before is tissue quality. And this actually comes back to thinking about prior injuries where he'd had a hamstring strain before on both sides. He'd also, interestingly, before we started addressing this problem, because it started to get exacerbated towards the end of the season, earlier in the season he sprained his ankle on that side, which it was a relatively moderate ankle sprain, sort of inversion type injury. Seemed to have a bit of involvement of his superior retinaculum too, but that settled down as well. And so I was thinking, well, maybe I need to also spend some time of assessing his tissue quality in terms of actually what it feels like through that particular chain in his leg, and think about, are there any restrictions? And we've talked a bit about some of these ideas with regards to sliding mechanics, of thinking of what can happen following an injury, or what can happen following, say, being sedentary or immobilization where you lose that gliding. Because that's actually a really important factor for maintaining good movement capacity, but also thinking about how you get peripheral feedback from the tissue.
Yeah, you've spoken about this before when we spoke about manual therapy, because I think this is a key factor in the sense of like people these days, I don't think we talk enough about tissue quality.
Yeah.
What's the tone like? As you said, what's the sliding capacity? How does it move in relation to other areas of tension? And we know that obviously if you've had prior injury, that's going to change that unique tension about that area, particularly if there is a formation of densifications or scar tissue or some sort of restriction within that tissue.
And it's very common, like both with tendon pain, but also with prior soft tissue strain, that you see changes in neuromuscular patterns. And this is an example where we're seeing a reduction in peak force. So clearly there's an issue where he's either had long-term maladaptations like at a neural level, or he's not recruiting all of his motor units. And this sort of ties in again with thinking, why is he not responding to isometrics? Is there an issue with his neuromuscular pattern?
Yep.
And if so, what's actually driving that? So this is when I started to think, well, maybe let's have a look at this. Let's actually do some hands-on assessment. And this also raises an interesting point in itself of actually using your hands and actually feeling
as an
tissue.
assessment tool, yeah.
And I mean, it's interesting where the people who seem to understand that more than others are typically the people who work with elite athletes full time, because they do a lot of hands-on stuff and they feel those changes.
And they often have, like we've spoken of this before, but when you work with the same people,
yes,
you start to get an idea of, okay, what this person's tissue quality seems to feel like in general.
And also acute changes, whether that's related to post-game because of changes in, say, autonomic nervous system output, and also the peripheral environment because of inflammation from working the muscle, but then also too with potential more mid to long-term changes when you think about hypertrophy of the muscular connective tissue network and feeling the laydown of like collagenous tissue, which I think it's always interesting to work with, to feel some of the elite sprinters or jumpers, because that's so prominent to feel the density of the collagen network. In addition to the other end of potentially adipose tissue too, if there's someone who's become deconditioned or their anthropometrics have changed. But one of these things too is feeling that gliding motion. And we've talked about, I think the common thing people will look at or feel for is tonicity, but the other one is thinking about the interface between the deep fascia and the muscle. And so it's interesting to note that a particular plane through his left lower leg was quite restricted. And that was not just in the hamstring itself, but also down in his perineals, which, given the fact that he's had an ankle injury, given the fact that you often have potential changes in perineal function, is actually not surprising. And even up into his gluteal region, so specifically for him around the piriformis. So when I do hands-on work, I actually try to be as objective as possible. So actually, I remember the first time I thought, well, let's actually be thorough about this. Let's do some knee flexion peak force assessment pre-treatment. Let's do some post-treatment, and let's do it follow-up session. Because the reality is, if you do manual therapy, most of the time people jump off of the bed and go, geez, I feel so much better.
Yeah, but that's a subjective view. And
it's also transient, typically.
And it may just be related to the fact that they want, people will feel better for being physically touched.
Absolutely. And look, don't get me wrong, that still has benefit. Clearly if you're working with an athlete as a part of their warm-up, you might do that because even if it is transient, if they feel better and it improves their mechanics, it improves their range of movement, whatever it is, great. So we did our knee flexion. It was still down. By this point, it wasn't as much as 40%. It might have been like 20, 25%, but still quite significant. And I also assessed both sides because it's always good to think of, is this a more centrally mediated change or is it more of a peripherally mediated change? And so interestingly, after doing some work on him, we saw massive improvements in his knee flexion. So when I say massive improvements, we're looking at a 0% deficit. In fact, I think if anything, it might have been like 1%. And the right side, the unaffected side, hadn't changed.
So it wasn't that, as you said, it wasn't a global improvement because you've input.
Well, interestingly enough,
therapy.
Just again to try and be an objective, I reassessed his knee flexion after treating each point. So I started with his hamstring, thinking surely the hamstring would be the most relevant one. Didn't actually change his hamstring output. Okay, let's work down on the calf because he had that injury prior to
ankle,
prior to the exacerbation of the symptoms. And after that, that's when you saw the massive jump.
It makes sense from just like a really basic, anatomical point of view. We know particularly say that if it was, some of the work through the perineal region, that's associated with the head of the fibula. The attachment for the head of the fibula is associated with the hamstring tendon. If that is actually bound down and is not moving, and you don't have gliding through that superior tib fib joint, through that inferior tib fib joint, you don't have those rotational qualities about the knee, you're going to be putting a unique type of tension through the hamstring, and it's going to, as you said, restrict its ability to move, to glide, even contract well.
Well, and also too, this is important to remember, what is the actual function of the fascial network? Part of it is to transmit forces, but the other thing that the deep fascia is highly innervated by is mechanoreceptors involved in proprioception.
Yeah.
And there is research looking at how we see changes in function of a muscle within an adjacent region within the kinetic chain. So you can actually have, for instance, a hamstring injury and see changes in function of the musculature in the back, or potentially vice versa.
Yeah, and I think this is, like we've spoken about this heaps, and your knowledge is better than mine, but this is the idea of sensory motor control, not just motor control.
Well,
the input that comes back from the tissue itself is going to influence the output that is possible within that tissue. So by changing that tissue quality in whatever way, or even giving feedback to that tissue, you're potentially, as you said, changing those recruitment patterns, you're changing the way in which that tissue can function.
Yes, and this goes back to, again, a lot of this literature comes back to the Stecco group. But we know that when you contract, you're seeing gliding between interfaces. And these interfaces are the deep fascia, specifically related to the aponeurotic fascia and the epimysial fascia of the underlying muscle. And we know that there is continuity within the fascial network. So, for instance, when you tilt your pelvis, we know that the deep fascia of the posterior chain causes fascial movement or gliding, not just at the hip, not just at the hamstring, but all the way down to the calf and the
probably
Achilles.
All the way up to the nuchal line.
Correct. In fact, it does. And there's also thinking about the impact of sensory motor or neuromuscular patterns. We see changes in, say, the neuromuscular patterns of the neck when you start to see changes in tissue gliding in the lower back and vice versa. So these are really not even hypotheses putting forward. This is actually research to actually support this claim already.
Yeah, well, we spoke with Adam Bryant about that research they did with Andy Franklin Miller in the mid-2000s.
I think about strain gauge through the lower leg with the passive straight leg raise and seeing that the strain at the Achilles tendon for a passive straight leg raise is the same through the hamstring and the back. And people would go, well, hang on, how is that actually relevant? Like, how is that possible? You're flexing the hip. All you're doing is lengthening the hamstring. And people forget that you're not just lengthening muscle, and more important, muscle isn't in isolation. It sits
part
in
of this
parallel,
connective tissue network, yeah.
Exactly, to the connective tissue and has myofascial expansions. Hence why when you move a leg passively or move a joint passively, the tension that you see distal is going to be more when you do it actively, because contraction of the muscle will create more tension through the fascial network. And this is where it's really important to think about if you have a reduction in gliding because of changes in the loose connective tissue between the layers, the signals, that is going to increase the tension that those mechanoreceptors pick up within that area. That sends signals back to the central nervous system that will have interneuron connections between two other areas within the kinetic chain that may inhibit your ability to contract the alpha motor neuron. So, yeah, going back to this case, so we saw the most significant changes working in that perineal area. And obviously, afterwards he was interested. One thing that's really good about this particular patient is he's very, very stoic. He's someone who I feel like the placebo effect is going to be minimised in someone like him. So interestingly, he came back a couple of weeks later, and straight away he reported big improvements in his hamstring tendon symptoms, but also was able to now get up to high running speeds and not experience those similar symptoms as well. And so, trying to be pragmatic about it, I had a look at reassessing his knee flexion peak force to see, is this actually still
being maintained, yeah.
And he had a 0% difference. So this is a pretty powerful tool because, again, we were using a lot of the typical interventions you would think to strengthen the muscle, i.e. loading it and progressively overloading it with higher intensities. And although we'd seen a slight improvement, we had a significant jump from using manual therapy to improve his tissue quality. And so he highlights too that the issue for his sensory motor function was not so much from the motor element, but from the sensory input, from those afferent signals inhibiting his ability to contract his muscle. And so interestingly, following that, he really started to see a quite significant jump in his ability to perform tasks and actually remove the constraints with regards to him being able to essentially do the things that he wanted to do and not actually have to worry about symptoms. And to be fair, at that point, we didn't need to make much change because we had implemented a resistance training program. He had built up his intensity and volume in his high-speed running. So he really was hitting all those markers. It was more just the symptoms and the peak force reduction, which, again, from my standpoint, it's like, is this something that we really want to just ignore going into training and competition because, is he going to strain his hamstring because of it? And now, hopefully he's actually at a point where
have you reviewed him recently?
Yeah, in fact, I reviewed him recently, but actually for another problem. Has
he been playing football?
Well, he's in pre-season. Oh, sorry. Yes.
Start, yeah.
No, they've had a couple of games. So I saw him last week. He played his second game. He came in just with some mild groin pain, but nothing too significant. So he's actually been having a really good outcome. The hamstring issue hasn't been a problem since.
So it's been maintained since then.
Yeah. So, it's interesting because we were talking about this particular case and presenting it, and it's interesting because it's interesting in the sense of the actual outcome, but it's interesting to talk about manual therapy in itself.
We're patting you on the back, Joe.
Well, look, it's one of those things that I think for me, I've also been guilty of ignoring manual therapy. I think I certainly, when I graduated and started working clinically, was very much influenced by everything should be very exercise focused. And the reality is, when you think about seeing a strength deficit, the clear thing is, we just need to do some strength work. And don't get me wrong, that's typically the approach I follow myself. But it's also a good example of I didn't see the outcome that I expected. I didn't see the improvement in his force producing capacity within a time frame that seemed reasonable for this person's age and adaptability and presentation. And so it really started to ring bells in my head of, what am I missing here? Because I don't think that should be acceptable, or you should just see that as, well, you're just going to have to deal with it, considering that he had no prior significant injury or any indications that would suggest that he doesn't have the capacity to continue to build his overall hamstring function and therefore see improvements in his tendon symptoms.
Yeah, I think it's an interesting case study for the simple fact that it's not common. I don't think this is always the most common presentation, but it highlighted very clearly how our understanding of something like all the tissue property of his tissue quality and its sliding mechanics and its relation to areas of restriction had a massive influence on, as you said, that sensory motor control and sensory motor output. And I think it's something that we don't necessarily always consider, because generally, unless that patterning has been as affected, the interventions that you put in place were actually going to cover off on that. And I think what makes this almost a bit more complex too is that sometimes the interventions that you do put in place will actually address that, even though you're not necessarily aware that those interventions. So like you might have put in, for instance, some sort of flexibility exercises as part of the protocol.
Yeah.
And that might have actually started to address some of those things. So you saw that deficit decrease. And in your mind, you're thinking, oh, it's because we've been doing the strength exercises. But maybe it's because you actually implemented a mobility scheme that actually addressed that ankle function and that calf function in a way that unlocked this capability of getting that sensory motor input.
Yeah, no, totally. And this comes back to thinking of their input versus output component, where like ultimately the thing that we're interested in is like, how do we actually optimize the output and therefore outcomes of this person? And I use this as an example. I mean, two things. One, to actually highlight thinking about tissue quality. But I think more importantly, it does happen where you don't see the outcomes you expect. And therefore you need to think about, is there particular variables or is there data that I haven't collected that's not leading to the emergent patterns that I expect to see? And this could be related to because you haven't addressed biomechanics, or because there are other stresses in that individual's life that are affecting their response to training loads. We could go on for ages here. I think this has been a particularly interesting thing for us, because it's probably been a thing that recently we've discovered, of thinking about, well, what can manual therapy potentially do, even at a tissue level?
You mentioned it earlier, and anyone who works in sport understands, based on actually the feedback that they would get from the people that they work with, that manual therapy plays a very big role in athletes achieving their optimal output. Yep. Now, if you want to be a skeptic, and you can be, you'll say, well, that's just placebo. They just like the physical touch and it makes them feel better to having known someone's done a little bit of manual therapy on them. Yep. But what you're highlighting here is that actually probably isn't necessarily the full picture. In fact, it's probably only a small part of why they feel better.
Well, absolutely. And look, there's actually a lot of very good literature showing that a lot of mechanisms associated with manual therapy are centrally regulated and are actually related to emotional centers of the brain. It's actually even interesting. I remember, this is just a bit off topic, but shows you the power of potential thought, that the manual therapists, their focus on when they're doing manual therapy has shown to influence the what particular areas of the brain highlight in the patient that they're treating. So it's interesting, because I think that highlights too that you have to be careful in what you believe, because if you are doing something that you don't believe in, the patient probably will pick that up. But besides the point, there are also peripherally mediated mechanisms we know with manual therapy. And some of these actually have to do with how it regulates the actual tissue environment from an inflammatory response, hence why doing general manual therapy is so valuable for athletes who are going to accumulate metabolic byproducts and pro-inflammatory markers in response to mechanical stress and oxidative stress, but also potentially changing the tissue mechanics by altering fluid dynamics and also the structure of the loose connective tissue, which is that substance between the deep fascial layers that actually determines whether you get a certain amount of gliding or not. And this is something that is a relatively new area of research. I mean, there's quite a growing body of research now looking at, say, for instance, changes in the sliding of, say, the thoracolumbar fascia in people with chronic low back pain, and how there's different factors that influence the viscoelastic properties of the loose connective tissue. But then we need to be thinking of, well, what kind of stimulus can we apply to alter that? And you sort of mentioned this before, because one of the things that's really important is shear forces. And so, when you think about manual therapy, particularly using certain techniques, you may be able to apply very localized shear force to change the viscoelastic properties. But we can also potentially use other modalities like stretching through large ranges, because we create large shearing between different sublayers.
For those people, I think it's one of the reasons why something like a Mulligan method works quite well, because you tend to, it's obviously mobilization with movement.
Yeah.
But I think that what that often does is it kind of tacks down one end.
Yes.
And then with the movement, you're actually trying to get that shearing of those different layers of tissue. Yeah. Now, typically with that method, you're using, joint. You're stabilizing at a joint and then asking them to move about that joint.
Yep.
But obviously, as we've mentioned, those connections with the connective tissue network cover the joint. They have, parts that go into the actual capsule of the joint, or they have, connections with the aponeurosis, with the retinacular. So by actually holding that down and cinching that into a spot, you actually may potentially be getting some of it. So it's not to say that you have to use one specific method, but there does seem to be, as you said, some association with that shearing effect.
Oh, totally. And you might be using other techniques, whether it's myofascial release stuff, where you're sort of pinning a point, similar to Mulligan's, or pinning a point, but then passively moving through range. Yeah. I mean, you see people use cupping and moving through range too, because it makes a lot of sense when you create that traction type force and then start to create active movement to potentially enhance the shear forces that occur at that level.
Because this has made me think too, because I think that there's sort of two factors in this, and it kind of became really relevant to me from that coaching perspective. I spent a fair bit of time over in the US. For those people who would be aware, there's a group called ALTIS. This used to be called the World Athletic Center, and they're a high-level group based in, at the time they were based in Arizona. They've now moved to Georgia, but they have a course that's called the performance therapy course. And they're adamant that exactly what you highlighted, Jack, that if you actually have manual therapy inputs that improve tissue mechanics, improve the tissue quality, reduce the likelihood of there being a restriction in that sliding capability in the joint function, then what you're going to get is an overall improvement in that sensory motor output. And they live by that. They're doing therapy all the time, not because of injury. They're not doing it because someone is sore. It might be because they're a bit sore, but generally they're actually doing it because they want to see an improvement in function. Yeah. They want to see an optimization of performance. And if you're doing those inputs consistently, then potentially you open up the opportunity that they can be training at a high level, racing at a high level, and performing at their best.
Yeah, I mean, we've talked about this in a previous podcast, but manual therapy currently has a bad reputation.
Well, it's weird because it shouldn't.
No, and part of that is actually just looking at how poor the literature, how poor the research is. If you look at, say, treating low back pain with manual therapy, do you think the diagnosis of low back pain is
appropriate enough? Yeah,
when
it's
you think
probably
about,
way too broad, isn't it?
Absolutely. And part of that, and thinking about non-specific low back pain, is probably thinking about how the myofascial system's involved in actually producing pain. But more importantly too, just because it shows that manual therapy isn't effective, that probably highlights that maybe that's not the main intervention that you need to apply in that population group, particularly if they are general population who have the typical characteristics of being unhealthy and sedentary.
Well, I think this is a really relevant point. Right, the thing that probably meant that manual therapy was more useful for this individual was because they actually covered off, you said it at the start, he covered off on a lot of the general health and physical capability areas. Yep. And we've spoken about this when we spoke about, when things aren't going well, in a previous podcast, about the fact that if a system hasn't got much stress tolerance, then improving those stress tolerances is probably going to give you a good outcome no matter what the stressor that you apply. So, for instance, if he'd had no training history and he just took up playing footy and then developed a hamstring tendinopathy, him just doing some strength training probably would have alleviated a lot of the discomfort because you're upregulating his force output, his stretch shorten capabilities and those things. But as you mentioned, he actually had a lot of those features already. He was already in the gym. He was training consistently. He's healthy. He eats well. He wasn't overloaded in other areas. So it actually starts to eliminate some of those features. And then you have to, as you said, you have to start thinking a bit more nuanced about, okay, are there tissue restrictions? Are there tissue quality problems that I actually need to look into because I'm not seeing the function in that area of the body that I think is reasonable?
And apply that principle more broadly, because it may not be that as the main factor. It may be something else, but that comes back to what bit of information am I missing? Because I think that's probably I'm always willing to go like, I think I can do better, and I think there's a solution to this problem.
Well, that's the thing. I think like the fact that he was saying like, look, I can still do everything, but it's not right. And you're looking at this result going like, why the fuck is this, this knee flexion test not improving? Like, we're doing all this loading.
Well, and look, I often think that too, of the humans are actually very adaptable. So there are obviously exceptions to this particular statement, but you should be able to achieve a really good outcome in terms of seeing the changes in their signs and symptoms, but then also their objective measures as well. There are obviously some exceptions to that, if like following serious trauma where there's perhaps like structural change to their musculoskeletal system.
Yeah, that is not necessarily going to remodel in a way that restores the previous structure.
Absolutely. So then it always comes back to, well, what are things that regulate their soft tissue or their musculoskeletal system, and what types of stimulus does the musculoskeletal system respond to? And I think those actually are two really good points to then think about and contemplate. Now, obviously, one of those is mechanical load, and we've talked about this a lot, and certainly that I think certainly forms a foundation for managing most musculoskeletal injuries, and then thinking about how mechanical load comes in different types of there's different types. And it's actually interesting because like manual therapy itself is actually a mechanical load. It's just that the kind of mechanical load is actually very unique because you can obviously localize it and it creates more of a compressive or shear force. That itself actually leads to certain cellular responses and adaptation.
It's funny you say that because I don't think most people see it as a mechanical force.
Yeah, well, I mean, there is research showing that, say, following like a serious injury, like you've had a surgery or you've had a fracture where you're immobilized, manual therapy mitigates the atrophy process. Now, don't confuse that here. I'm not saying that manual therapy is going to lead to hypertrophy. I'm saying that...
Why not, Jack?
Well, you can try. See how you go. It's certainly not going to be replacing the degree or magnitude of mechanical force you can apply with doing resistance training. But that straight away shows you that you're getting a cellular response that leads to changes within the tissue environment or the genetic signals to synthesize protein. And so with that in mind, the more you actually learn about, well, what is actually happening at a cellular level, I think that's when you can start to really think about when manual therapy is appropriate and how it fits into potentially creating changes that are unique to manual therapy and how that fits in with the other interventions that you're applying.
You mentioned research there. I know that your understanding of this is much deeper in terms of the literature than mine. Do you have somewhere that people can go if they want to start looking at some of this stuff? If they want to look, I know you clearly have mentioned the Steckos before. And we're planning on obviously chatting with Antonio Stecco. So we will obviously be able to highlight their work. And so that's obviously a great starting point for people who want to understand more about the fascial network and some of these understandings anatomically and the utilization of, say, certain manual therapy techniques for that. But you've mentioned a lot of areas, particularly related to sensory motor control and the effect of manual therapy. Are there people that you would recommend that individuals go and seek out their research?
Well, I think in terms of understanding the complexity of the sensory motor system and how peripheral tissue quality factors influence sensory motor output. Some of Paul Hodges' work is
He's actually really evolved.
Pioneering.
Yeah.
It's really pioneering. I mean, he's someone who obviously is quite well known for some of his early research with Gwen Giles of looking at changes in, say, EMG patterning with chronic pain. One of the things I really like about him is he's really expanded on that, because I think some of the ideas that came from that initial work of using internal cueing have limitations to the outcomes that people expect. And he's really starting to show that we can, one of the big things that influences those afferent signals is the tissue quality when we think about fibrotic tissue, or maybe even think of that spectrum from densification to fibrosis, and how we can mitigate that. Because interestingly, some of the research that he's found so far is applying general mechanical forces early stops the maladaptation or pathological process.
Fibrosis kind of formation.
Yeah, so certainly I would recommend looking at some of Paul Hodges' work, because that's really, I think, pioneering in terms of understanding sensory feedback influencing motor output.
Yep.
And I mean, I'm actually quite, it's funny, one of those things, I'm quite big now thinking about definitions of terminology, because we always hear motor control. We actually need to use the word sensory motor control, because then you start to capture the other side of the equation.
Would you? I know in the past you've spoken about people like Daniel Wolpert. Would you push people in the direction to look at some of his stuff?
Well, I think some of his stuff is looking at a much more broader level of understanding neuromuscular systems and factors that influence it. I mean, his stuff is getting into the real weeds of neuroscience. Some of it, which it even goes a bit beyond my head. But I think his work really highlights what you would call complexity, and understanding that the sensory motor system is involved in is defined as a complex system. What his work really highlights is we can't just limit it also to thinking of peripheral feedback and efferent output. There's so many factors in between, particularly at a cognitive level.
Yeah, and the environmental factors and how contextually that changes so much of that input and output.
It's really getting into, it really helps you to understand and I think appreciate looking at the sensory motor system as the thing that we can focus on is the output. The thing that we can see is, are we seeing an output that we would like? And we could see that in regards to looking at things like flexibility, like strength, power, elasticity, and then also the biomechanics and movement pattern. But understand that so many things influence those particular outputs. So
I think the key one, it's always funny, we've spoken about it when you spoke about flexibility and stretching, is what happens when you shut the lights off. Under anesthetic, people's capability of movement is completely different.
Yeah, exactly.
And that is such an illustration of the number of centrally mediated factors associated with movement itself.
Yeah, no, absolutely. That's a whole nother area to go into. But I'm just actually looking up some other authors. I know there's a good study by, I think you pronounce his name Bialosky, Bialslossky, called...
So do that again.
Well, maybe just look up the title. It's called Unraveling the Mechanisms of Manual Therapy. I think that's actually a good review of looking at the manual therapy literature to start to understand what information is out there.
Yeah.
Because there's actually a lot more than you think. And I think this also comes back to looking outside of research published, just say, in physiotherapy journal articles, because there's a lot more research out there, even from other professions too, that really help us to better understand the mechanisms behind manual therapy. And then with that, thinking about, well, manual therapy is a broad term of different types, different intensities, its application with regards to other types of training modalities, to really then think about how we better utilize it in conjunction with other training or other interventions. I was just thinking about, is there any other particular work I would recommend? Look, I think if you're really starting off looking at some of Stecco's work, if you're looking at some of Paul Hodges' work, if you're looking at some of the Bialosky, I'm assuming that's how you pronounce its work, there's a really good starting point. I think even too, typically when you start to look in that, it starts to only bring up more research and more opportunities to look deeper into some of these areas.
In terms of this case, what do you think are the key things that were important that, we highlighted, making sure that you're not missing things? What key things do you think are important for someone who maybe has a case that's not adding up? What are the key things?
Well, actually, I think the value of this study is more of thinking of the interaction of different interventions. Because what this, I think, highlights to me is it's not that he didn't need to do all those other things that we did. That's certainly not saying that I should have just done manual therapy to begin with and he would have been fine. It's showing that the biggest modulator for changing his hamstring function was to do with like peripheral tissue mechanics.
Yeah, exactly.
That created the step change that led to a significant improvement in his overall output. He was someone who I think needed to work on improving some of those other things. That's not to suggest that that wasn't important. It just goes to show you that the output is also influenced by the interaction of all those different stimulus. And for him, there was a big one that I was missing that turned out to be the bigger catalyst for seeing that real nonlinear change ultimately for him. That obviously that's a quite a unique example of the significance in change, but it nevertheless highlights something that I think we talk about clinically and with case studies with our colleagues of, what's the missing piece? Because I think that's often can be the thing that leads to you having an average or suboptimal outcome, or potentially a negative outcome. You're not seeing the result you want by going, right. There is actually an answer to this. It's part of it is because of the one thing or one variable I haven't addressed yet.
Jack, thank you very much for sharing this case study. I think it highlights some very important things, and we hope those people listening get the opportunity to explore some of that research. As always, if you've got questions, feel free to send them through.
And I think actually with that in mind, I'm thinking about where to look. Again, feel free to contact us. I'm obviously happy to share any resources or articles I have and hopefully help you out or point you in the right direction.
Thank you for listening.